Yeah, good morning, good afternoon, good evening, wherever you are. Welcome to that Oil Fusion webinar this night, and we are welcome you. I welcome you on behalf of the European board and on behalf of my co-moderator, Reinhard Onasch. And we have a very interesting topic, I guess, this night. We have also a lot of pre-registrations, and I see a lot of greetings from the whole Europe and the whole world, and welcome you to that webinar on temperature management. We have very good guests this night. First of all, my good old friend and colleague from Germany, that's Professor Benck. He is a perfusionist since, Christoph, more than 25 years, like me, and he's doing a lot of research also in our topic. And he will present his experiences and his knowledge about temperature management, and that in a special situation in the ECPR situation. And after that, we have a colleague invited from the US, and I will welcome you, Clint. You are from the Mayo Clinic in Rochester, and I'm very happy that you are here and that you will talk about the guidelines to temperature management, and will give us a little bit look behind the story, how to manage temperature during cardiopulmonary bypass. But first of all, Reinhard, you will bring us into the topic, into the background with a presentation, and then you play the ball to our colleagues. And Reinhard, that's your talk, and probably you can say just 2 words beforehand and then start your presentation.
Thank you, Adrian. Good evening to all of you. I'm very glad to welcome you to this webinar, and at first I will start with a short introduction and a presentation to our today's topic, the temperature management during cardiopulmonary bypass and resuscitation.
Just one thing, while you start your presentation, please, colleagues, you have the Q&A section below. Use that, give us comments so we can react, and also the presenters can react and send you answers back. Thank you.
Thank you, Adrian. Just a moment to, okay, now I have the presentation. At the beginning, I will give you an overview on topic-related points. First, I will focus on the purpose of hypothermia in cardiac surgery and cardiopulmonary bypass and give a brief overview on temperature management in the past. Then I will talk about evidence and the importance of guidelines for daily practice. And finally, we will take a look at the current evidence of our topics today. The beginning of hypothermia as a useful tool for cardiac surgery is often described with the experiments of Bigelow et al. In 1950. They suggested that systemic hypothermia might be of use. They monitored parameters such as blood pressure, heart rate, and cardiac output during cooling and rewarming of dogs. The goal was to determine the suitability of circulatory arrest to repair defects in bloodless hearts. The dogs in this trial were cooled by surface cooling. In 1953, the first successful closure of an atrial septal defect was performed using systemic hypothermia at 28 degrees Celsius and based on a similar surface cooling concept. Later in 1970, a combination of surface cooling and rewarming with the use of cardiopulmonary bypass during the repair of complex congenital cardiac defects was described by Barrett Boyce et al. Using the cardiopulmonary bypass for both cooling and rewarming was described by Hamilton et al. In 1973. The purpose to cool down the body during cardiac surgeries is to decrease the metabolic activity and following the reduction of oxygen consumption. The ischemic damage to tissues should be minimized this way. In the graphic, you can see the cerebral metabolic rate of oxygen consumption at different temperatures. These findings were recorded during the observation of dogs who were cooled down to 14 degrees Celsius with measurements at different temperatures. As mentioned, in cardiac surgery and cardiopulmonary bypass, we use the mechanism of a decreased metabolic rate during hypothermia. Originally, there were mainly descriptions of the probability of the technique. In 1995, Williams et al. Noted that hypothermia was mainly empirically established. With the rise of evidence-based medicine since the 1990s, more and more reviews and guidelines have been written based on the best scientific evidence. Guidelines summarize the best scientific evidence on a particular topic. They are great for advising clinical professionalists. The recommendations made in guidelines are usually described by a class of recommendation and a gradation of the level of evidence of the underlying literature. The class 1 recommendation is the highest recommendation available. Class 2 describes a recommendation that is based on conflicting evidence and is divided into subgroups. Class 3 is used when there is evidence or general agreement that a treatment is not useful or effective and may sometimes be harmful. The recommendations given are based on the available scientific evidence. This evidence is graded by the quality of the study. The highest level of evidence describes data obtained from multiple randomized controlled trials or meta-analysis. The lowest level of evidence is based on expert opinions or smaller studies. The classification shown on this slide is mainly used by European guidelines, whereas the ACC/AHA classification is more common in the US. In 2002, Bartels et al. Concluded that the available scientific data is insufficient in both amount and quality to serve as a basis for practical evidence-based guidelines for CPB. 13 years later, the Society for Thoracic Surgery, STS, the SCA, the Society for Cardiovascular Anesthesiologists, and the American Society for Extracorporeal Technology, MSACT, reviewed the literature and published a guideline for temperature management during cardiopulmonary bypass. Other topic-related recommendations for clinical practice are the MSACT standards and guidelines from 2017 and the 2019 European guidelines. The recommendations made in the 2015 guidelines are mostly strong recommendations. These recommendations are mainly based on a level of evidence C and are retrieved from expert opinions or smaller studies. Afterwards, we will learn more about the content of these guidelines from Clint Corby. In the 2017 MSACT standards and guidelines, there are temperature-related recommendations that could be translated in a Class B recommendation. According to these guidelines, the monitoring of the temperature shall be employed on the arterial outlet, and various temperatures of the patient and the devices used shall be monitored continually during cardiopulmonary bypass procedures. The European guidelines from 2019 refer to the 2015 guidelines and note that there was no need for any major update related to cardiopulmonary bypass at the time of publication. If there's newer evidence that could lead to stronger recommendations, these could potentially be integrated in future revisions of the European guideline. The current evidence for temperature management during cardiopulmonary bypass remains controversial. The latest guideline is 8 years old and is mainly based on expert opinions and smaller trials. Our second topic today is cooling and hypothermia during extracorporeal resuscitation. In the next 2 slides, I will give a short introduction and will summarize some of the findings so far. The first review is not related to eCPR in general, but emphasizes a rapid cooling strategy below 34 degrees Celsius. It appeared to be beneficial for neurological recovery for patients after cardiac arrest in this review. 2020, in a meta-analysis, Chen et al. Showed that the combination of therapeutic hypothermia and eCPR and may be associated with favorable outcome and survival. Some limitations with this analysis were synthesis of retrospective observational studies and therefore a lower level of evidence. Duran et al. Showed in another meta-analysis that the combination of hypothermia and eCPR might be suitable for patients with cardiac arrest and improving survival and neurological outcome. One point worth mentioning was that they did not find an increased risk of bleeding in this population. No differences in the observed endpoints were shown by the meta-analysis of Huang et al. In 2022. They compared eCPR with and without a targeted temperature management. Overall, regarding the temperature management during cardiopulmonary bypass, the evidence is limited and there could be possible need for updated guidelines. At this time, there's no specific guideline for hypothermia combined with eCPR, but some meta-analysis could serve as a basis for high recommendations in a future guideline. Now I'm excited to hear the presentations of our speakers to the related topics. Professor Christoph Beng from the University Medical Center Freiburg in Germany will start by giving us insights in this topic with a focus of eCPR and the role of perfusionists. After his presentation, Clint Coble from the Mayo Clinic in Rochester, USA, will talk about the temperature management during cardiopulmonary bypass, especially about the 2015 guidelines and changes since it was published. Thank you very much, and we are glad to have you as our guests, and thank you for your participation in this webinar.
Yeah, thanks a lot. Dear colleagues, it's a great pleasure for me to give a presentation about eCPR and cooling. So, when I was asked if I could give a presentation about eCPR and cooling, I could directly eliminate the question mark, because I think it's extremely important to cool during resuscitation. And first, my conflict of interest: I'm a CEO and shareholder of a startup company of the university in Freiburg, where we did a lot of research in resuscitation and especially in improve the results, neurological results of resuscitation using extracorporeal technologies. So the content of my presentation will be hypothermia in current CPR and looking in the current literature, because there is a debate or discussion due to the published studies, TTM2 trial, where hypothermia is still controversially discussed. And I will also give a short overview about current...
Sorry, when I interrupt you, your screen is not in front, so probably you have to retry to bring the presentation in front.
Okay, so let's check it.
No, it's still the presentation mode.
Okay, we checked it before, but now it's...
Technical things happen.
Let's check.
Do you use a second screen, Christoph?
Yes.
Probably it could help if you close that screen or the laptop.
Check it 1 second.
So this is almost okay. It's not the right one, but
No, let's try it. Sorry.
Okay.
Sorry. It's not working again.
Then Maria give you a hint in the chat. Probably that helps. Ah, that looks good.
Now it is,
Yes.
but I'm not able to move forward. Now you
Now
can
it's
see.
moving.
Yeah, it's okay.
Yeah.
Okay, sorry. So I will give a short overview about the current status of ECPR but Reinhard already gives you a great overview about the current evidence, and I will talk about our research project, CAL therapy, where we especially implemented hypothermia and how we use it in clinical practice, and also I will give you some first results of our first clinical trials. So the current challenges in resuscitation are completely clear for us. We have a high mortality in hospital. It's around 80%. In the out of hospital cardiac arrest setting, we have 90%, and the survived patients have only 15% of the survived patient has a good neurological recovery. And this is the graph who explains extremely easy why it is how it is. The time for successful resuscitation is extremely short. After 15-20 minutes, only 1 to 2% will survive without neurological damage. And the question, of course, why are the results as they are? We have a maximized output demand from a failing heart on the one hand side. CPR means always emergency circulation. We have no monitoring most often, and there is a generalized ischemia and reperfusion injury starting directly with the cardiac arrest. And if we are looking at the cascades of the reperfusion damage, you see the pathophysiology, there are many cascades are triggering the reperfusion damage. And what we know, if we are using hypothermia, it would directly reduces or prevents cell damage and of course the cell death. So let's first look at the animal studies on hypothermia during cardiac arrest. These are meta-analysis of 60 animal studies only related to cardiac arrest models, and almost all studies show an effect of hypothermia when it is used properly. So the overall effect of the animal study was mortality reduced by almost 70%. So looking at the human studies and how the guidelines changed in the last years. So in 2005, the HACA study recommend hypothermia 32 to 34 degrees. And when the TTM1 study was published, they published that there is no difference between 32 and 36 degrees. But in this study, there were several limitations. So there was an extremely short no-flow time, only 1 minute. And if you look at the time when the goal, when the temperature, the goal temperature was reached, was after 10 or 12 hours. Same in the TTM2 trial. They showed that there is no difference between 33 and 36 degrees, but the same limitation. We have an extremely short no-flow time, long time until they reach the hypothermia, the goal temperature. And they had a really high rate of basic life support of more than 80%. So if you look then at the first studies with normothermic conditions, and this meta-analysis showed it extremely nice. You see there are several studies, and while the single studies are not all statistical significant, in total, the meta-analysis showed that a TTM of 36 degrees has a worse neurological outcome. And some clinic followed the guidelines, of course, and this is a really nice paper from Australia where they showed the results of more than 60,000 cardiac arrest patients, and they tried during many months to reach their goal temperature. Goal temperature was 33 degrees, and you see that they are able to reach in the end 33.5 degrees in the middle. And then the guidelines changed, and immediately the temperature, of course, increased. So if you then look at the mortality, that's really interesting. During the increasing temperature period, they reduces also the mortality. And if they changed to normothermic temperature, the mortality is still increased. So if we look to the no-flow time and the effect of hypothermia, and in this publication from Testori in Resuscitation 2011, you can see that the effect is only after 3 minutes of no-flow time. So between the first and the second minute, there's no effect, no statistically significant effect of hypothermia. And we now consider the TTM 1 and 2 trial. The no-flow time was only 1 minute. Another extremely interesting study was a Japanese study. They are focusing on the lactate level at hospital arrival, and they divided it in 3 groups: mild, less than 7 millimole per liter, and moderate, less than 12, and severe, more than 12 millimole per liter lactate. And if we are looking now at the results, you see directly that the severe group will have a better results if they are in a hypothermic condition. You can see it here. It's statistically significant. And if we compare it again to the TTM 2 trial, or 1 and 2 trial, the lactate level was between 5.8 and 6.7. A study from the Netherlands showed different grades of encephalopathy: mild, moderate, and severe. In the mild, there was no difference also in the severe. But if we look at the moderate encephalopathy, you can see that there is a statistically significant better results in the hypothermia group. A next study, it was a network meta-analysis with more than 42 studies. They are looking for the time collapse to ROSC, and the survival and the good neurological outcome are closely associated with the time of collapse to return of spontaneous circulation. And in the group 20 to 40 minutes of collapse to ROSC, it was statistically significant better in the hypothermia group. And in this paper, and when we looked which patient could benefit and from those special parameters, and you can see that 40% of those patients who will get hypothermia could benefit from hypothermia. So in conclusion, for CPR and COOLIE, there are a lot of animal studies with a mortality reduction by around 70%. Real-life data that shows that what happens when hypothermia is changed to 36 degrees showed an increase in mortality. And data shows also that 40% of patients could benefit from hypothermia. And there's currently no study that shows that hypothermia worsens the outcome. So now the question, and this is a picture of the resuscitation registry from Freiburg. You see duration of CPR and the cerebral performance category 1 to 5. And you see that we are losing a lot of patients with conventional CPR. And the really famous cardiac surgeon Gerald Buckberg, when we started our research, said we save the heart, but we lose the brain. So the question, is ECPR the solution? And there are many studies that shows that ECPR is definitely a powerful tool to improve the results of resuscitation. But, and that is really, from my point of view as a perfusionist, a big problem, because ECPR is still an undefined therapy. And if you look in the literature, there's only one sentence: ECMO support was initiated, ECPR was implemented, ECMO was performed, and nobody knows what does it mean, which flow, which oxygenation, cooling, whatever. So to be honest, I only found one, let me say, good publication to ECPR and cooling. It was a retrospective analysis of the ELSO registry, and they showed that patients with intentional cooling achieving temperature around 34 to 36 degrees for 12 to 48 hours was associated with lower in-hospital mortality. But coming back to the beginning of my presentation, we have a uncontrolled, or we have a reperfusion injury, a ischemic injury, and CPR means that we have an insufficient perfusion with uncontrolled reperfusion. And our idea was, like we are doing it every day in the OR, arrest the heart and reperfuse the heart. So it should be able to implement it for the whole body. And that was the idea of developing a therapy and to increase or decrease the reperfusion injury. And the idea is using therefore a therapy bundle to limit the reperfusion injury. And this means that we have to control the reperfusion condition. That means that we have to control the composition of the reperfusion solution. And of course, we need therefore permanent monitoring. And one extremely important condition is temperature in this setting. And we called it the therapy CARL, from controlled automated reperfusion of the whole body. And one column is the fast and immediate cooling of the patient. Therefore, we developed our own system in cooperation with a company, the startup company from the university hospital. It's called Resuscitec, and we developed the so-called CARL system, and it's the first system for automated reperfusion system for the use in hospital and out of hospital, and especially focusing also to a special cooling device. So in comparison to a regular ECMO or ECLS system, the difference is that we implemented 2 pumps for a higher pulsatile blood flow. We implemented a lot of sensor technology, blood gas analysis on the venous and arterial side, pressure sensor directly in the connected directly to the system and implanted in the patient. We have a special device for adjusting the oxygen, but a really important device was the cooler, and that was one of the biggest challenges in establishing this system, because it is extremely difficult to have a high power cooling device out of the hospital. And therefore we use the technique everybody knows, maybe the reaction, the chemical reaction with water and urea, and with this setting in a cooler, you are able to cool down 80 kilo patient, for example, in less than 20 minutes, up to down to 33 degrees. And we compared it to normal ECMO heated cooler units, and you can see on the red line that we are able to cool down a patient in less than 20 minutes to less than 33 degrees. And that's extremely important. These are some data from our animal studies. If we compare it to a normal ECLS or ECPR setting, you see here we are able to cool down the patient as fast as possible to our goal target body temperature. And these are the data we are still discussing, TTM2 trial. And if you look at the graph on the right-hand side, these are hours, not minutes, when they reached the target temperature. So we are using the system in hospital. We have always a system available, completely primed. The cooler is directly fixed on the cart. It's central located in the perfusion department, and so we have direct access to bring the system directly to the patient wherever it's needed. Use it also outside the hospital. Therefore, we have a special emergency ambulance car. The project started before COVID and is since 2021 equipped with the CAL system and the cooling device, and we are available in the urban area of Freiburg, supported by the local emergency medical services. And we are using the prime system from the OR, bringing it to the car, and so we are able to with a special equipped car, so we are able to use this technology wherever it's needed. So the first results, and now I'm showing you the same picture in the beginning. The red dots are the conventional CPR, and the blue one are the CAL patients. And what we see now for the first time, we have patients resuscitated for an extremely long period, more than 1 hour, with an excellent neurological recovery with a cerebral performance category 1. So we started in different hospitals in Regensburg. They did a really great job, published the first 10 patients with a survival rate of 50% and neurological recovery also of CPC1 in all the survived patients. Currently, we are running a multi-center post-market clinical follow-up study. It's a study from the University Hospital in Freiburg, and in total there are 102 patients included currently. 67 patients received a complete CAL therapy with cooling. All the target parameters are reached, and the survival rate is currently 44.8%, and this is really extremely promising results. We initiated hypothermia in 100% of all the patients, and the goal was 32 to 33 degrees. 70% of the survived patients had a CPC 1 to 2 after 30 days. The mean duration of CPR was 45 minutes. The mean patient age was 60.7, and 55.6% of the patients was with an initially shockable rhythm. So we have an all-comer study. All patients were included in the study until now. So in conclusion, ECPR and cooling. ECPR offers a possibility for a direct cooling, not 10 hours later on the intensive care unit. Directly, if we implement the system, it is extremely effective. Directly via oxygenator and powerful heated cooler units, it's limited because we are only able to use it in the hospital, and there are not really clinical data available like a randomized prospective study. So I think we have to look what's in the loop. CAL is the first system especially developed for those patients with cardiac arrest, and it allows a fast and immediate cooling when the system is directly connected to the patient and wherever it is needed, in or outside the hospital. And it's one key reperfusion condition is the cooling and the reduction the body temperature. The first clinical results are extremely promising, and currently we are preparing further clinical studies. So thank you very much for your attention, and sorry again for the technical problems in the beginning. Sorry.
Adrian, you're muted to this point.
Thank you very much, Christoph, and no problem at all. That's webinar live. Such things happen, no problem. So very good. Thank you for that interesting insight in that new technology. And if I'm right, and to my knowledge, there are not so much machines out in the market able to cool the patient on the street, right? So and that's very special in your approach, and that's why we put you also in that webinar. You are also in that in that company. Do you have the feeling that it's there is a space for that technology? Do you have a lot of requests from the clinics and from the perfusionists and the intensivists? And
of course, as always, a new technology needs time, and I think we are currently in a situation that everybody is thinking about ECPR, but I think, and that's what I already mentioned in the beginning, what is ECPR? And you can run a heart lung machine, and you can run a heart lung machine, but I think they are completely different ways to treat a patient, and that's always the challenge to get acceptance. And of course, if you are using a cooler and a special oxygen device, and you have a system with more monitoring options, you have to carry more system. You have to carry more. It's more complex, and so yeah, I think it needs time, but the results are really promising. And when I'm talking about the research years, when we started in the animal model, we tried to avoid hypothermia because it's extremely complex to have hypothermia out of the hospital. Maybe you can use cold solution, of course, but it's not so effective if you have a real device and cooling directly to the patient. And the negative aspects of hemodilution is also known. But when we started in our animal model, it was impossible that the pigs survived without hypothermia. And even when we started with hypothermia, the results completely changed.
Okay, very interesting. Christoph, we are short in time, but we will discuss at the end a couple of questions that are already in Q&A section, and you can also answer them question already by writing in, and then we will discuss it afterwards. And then I give the word to Reinhard, and you can introduce Clint, please.
Yeah, thank you, and thank you, Christoph, for the insights of the CARL system and the hypothermia during extracorporeal resuscitation. Clint Colby would give us more points on the 2015 guidelines of the American societies, and will emphasize the evidence since it was published. Thank you, and good luck for your presentation.
Thank you, Renard. See if I can get it up. Oh, I lost it. Hold on.
You just take your time.
Can you see it now?
Not yet. There's a button for screen sharing on the bottom. And there you can share your whole screen or windows.
Let's see. It's weird if it's just kicked me out. Let's see. Still no?
No, not to this point.
Shoot. I just clicked on here. All right, let's see. I don't know what I'm doing. Here. That's all I did last time.
Then Maria, give the advice first.
Sure.
Presentation mode in
Okay, I'll
and the
go.
PowerPoint and then the share screen. First presentation mode in and the PowerPoint and then the share screen.
So I'm in PowerPoint. And then I open it up, and how do I share the screen? Sorry.
In the Zoom
Yeah.
window, there's on the bottom
No.
a
Okay,
button for a screen share. And then you can select the window from your presentation.
got it. I think I might have figured it out.
This is your presentation window. Okay, please try F5 again as a shortcut.
Still not working, huh? All right, let me grab it one more time here.
Yeah, if the presentation is already started, you can choose from 2 PowerPoint windows.
So is that working now?
Not yet.
Okay, I got to get you.
Now it's now it's the PowerPoint in. Okay, I think it will work for this moment.
Yeah. Do it in that mode. That's okay.
Okay. I'm excited. I'm Clint Colby from the Mayo Clinic in Rochester, Minnesota, United States. I'm excited to be able to speak on temperature management and anything that new has come out in the last few years that's new. I wanted to start out with the base, like Bernard said, and talk about the STS guidelines. It was formed as a joint task force by Dr. John Hammond, and he wanted to set up some guidelines here in the United States for, as you can see in the slide, to guide perfusionists in their practice. And you can see in 2015, they released a guideline and paper, and it was reviewed and published in 3 different journals here in the United States as guidelines for temperature management for cardiopulmonary bypass. And it would, to know this was anesthesiologists, cardiologists that reviewed these articles. Areas of focus were optimal site management for temperature measurement, avoidance of hypothermia, peak cooling temperature gradients and cooling rate, peak warming temperature gradient and rewarming rate. The paper did not evaluate ideal temperature for cardiopulmonary bypass. Renard touched on this earlier. ACC, AHA classifications on evidence base, and they made strong recommendations on things that were proven in the research. This is how they came up with the guidelines. They looked at 768 abstracts were identified and reviewed, and only 39 of them were accepted. And out of they had those 39 that were accepted by at least two of the reviewers. And then they added in 13 papers and abstracts. And from this, they have class 1 recommendations that are strongly recommended. The oxygenator arterial outlet blood temperature is recommended to be utilized as a surrogate for cerebral temperature measurement during CPB, cardiopulmonary bypass. To monitor cerebral perfusate temperature during warming, it should be assumed that the oxygenator arterial outlet temperature underestimates cerebral perfusate temperature. Surgical teams should limit arterial blood outlet temperature to 37 to avoid cerebral hypothermia. Temperature gradients between the arterial outlet and venous inflow on the oxygenator during CPB cooling should not exceed 10 C to avoid generation of gaseous emboli. I have an article that will talk about this that has recently came out that somewhat challenges this point here. Temperature gradients between the arterial outlet and venous inflow on the oxygenator during CPB rewarming should not exceed 10 C to avoid outgassing when blood is returned to the patient. Less strong recommendations that came from the guideline, pulmonary artery or nasopharyngeal temperature recordings is reasonable for weaning immediate post-bypass temperature measurement. Rewarming when arterial blood outlet temperature is greater than or equal to 30 C. To achieve the desired temperature for separation, it is reasonable to maintain a temperature gradient between arterial outlet temperature and venous inflow of 4 C. To achieve the desired temperature for separation from bypass, it is reasonable to maintain rewarming rates of less than or equal to 0.5 C per minute. Rewarming when arterial blood outlet temperature is less than 30 C. To achieve desired temperature from separation, it is reasonable to maintain a 10-degree gradient between arterial and venous inflow. Now we're getting to the good stuff here, the new stuff. The guideline doesn't specifically talk about an optimal temperature during bypass. And then there's no recommendation or guideline is provided concerning optimal temperature for weaning from CPB due to insufficient published evidence. And now the talking points that I'd like to go over and share some studies. Optimal temperature management of CPB, warming and cooling rates and what's new, optimal temperature for weaning from bypass, and there's a few miscellaneous items that relate to temperature management. All right, optimal temperature management during CPB. Here in this study, mild hypothermia during cardiopulmonary bypass assisted CABGs. This was an 18-year cohort. And you can see the prevalence of mild hypothermia compared to moderate hypothermia compared to normothermia. And you can see that as you get closer to 2015, there's more prevalence of mild hypothermia and normothermia being utilized for bypass. And there's a reason, there's evidence to show this. Here is a study, hypothermia and operative. Hold on one second, I'm going to move this so I can read all my notes so I don't miss any key points. This was a study published in 2014 by Dr. Greason and Dr. Suri and associates, surgeons at the Mayo Clinic at the time of the study. This study was in 2014, which was close to when the guideline was released. And it's hypothermia and operative mortality during on-pump coronary artery bypass grafting. It talks about controversy paired with hypothermia compared to normothermia. And 3 groups were divided into normothermic group, mild hypothermia, and moderate hypothermia. Most patients in the SCS-ACD who underwent on-pump CABG and core temperature during the procedure of less than or equal to 36. Patients who received hypothermia demonstrated a significant mortality benefit compared to those who maintained normal temperature. This is widely known, as we know, but there's challenges to some definitions here in these papers on what is described as mild hypothermia. Greater degrees of hypothermia, i.e. less than 34 C, showed no benefit over mild or normothermia. Okay, so published in 2021, and this covered 6,525 patients. There was some propensity matching for surgeon preferences. So some of the surgeons were always in certain groups here. So there's some lack of strength there, but mild hypothermia versus normothermia in patients undergoing cardiac surgery. Mild hypothermia, hold on, there's one key point on the last slide that I forgot to discuss. They talked about how mild hypothermia was classified as 32 to 36 C. And most agree upon that 35 C is more readily mild hypothermia. So their study actually only had normothermic over 36. In this study here, they described mild hypothermia as defined as 32 to 35 C, and normothermia is defined as greater than 35 C. Postoperative acute renal failure and length in the ICU was significantly higher for the mild hypothermia cohort. Normothermia had the best outcomes between 35 and 36 C. Mild hypothermia during cardiopulmonary bypass assisted CABG. This is that 18-year cohort study again, and it was published in 2022. And here's some interesting graphs that they show the differing survival rates for the differing groups. This covered 5,672 patients. Highest survival bypass temp was 32 to 35 C. They targeted the 32 C, but as you get closer to the 35 range, so 32 to 35 show the greatest results. Here's these were big meta-analysis studies. The top one here was published in 2021, covered 9,609 patients. This is from the actual article. The existing evidence for an organ protective effect of hypothermia in adult cardiac surgery is low and inconsistent. The second one down here is also a meta-analysis from 2022 covering 6,690 patients. And this is from the paper also. No clear evidence exists regarding a possible superiority of normothermic or hypothermic CPB. Now I'd like to, it's not the end all, and I don't want to, I'm just going to share tidbits here on the end of each of these sections on my Mayo experience and kind of trends that happen here at the Mayo Clinic. No one cools below 34C for even some pretty significant cases. Like last week, I did a double valve myectomy maze, and we stayed warm for the entire case. As long as you're able to oxygenate, things are fine. And I was thinking from my experience that about 90% of all single valve CABGs, myectomies, shorter, anything under 2 hours, they're all used under normothermia. Okay, now I'd like to share a couple studies on warming and cooling rates. This first one here, rapid cooling is safe technique if patients undergoing circulatory arrest. This was published in 2022, 2,171 patients. This was a retrospective study that looked at perfusionists that set their heater coolers to 0C. This was in all-in-one center. And the conclusions of the paper that rapid cooling gradients greater than 10C can be performed without any increased mortality or morbidity. This obviously goes against the guidelines, and this is one study. But I found that this was pretty significant. I mean, 2,000 patients, and pretty consistently here at the Mayo Clinic, we turn our heater coolers down pretty cold, at least initially, while we maintain making sure that we don't go any lower than 13.5C on the arterial inflow. This is a confirmation of the standards and guidelines touching on warming. This was a rat study, and it was published in 2020 by Lenardi and Associates. And it's among the factors that affect neurological outcome after hypothermic circulatory arrest. What is the role in rewarming? The rewarming rate influences inflammatory activation, oxidative stress, microglia activation, and cerebral flow. Higher rewarming rates increase inflammatory response and could influence neurological outcome after hypothermic circulatory arrest. The study was conducted on 44 rats. The circ arrest time was 60 minutes. The slow group was, they were rewarmed at 5C gradient between the arterial and venous. The fast group was 10C. Higher rewarming rates increased inflammatory response to higher rewarming rates. Slower rewarming rates leads to better recovery of cerebral blood flow and reduction in cerebral edema. Here, the Mayo experience that we've abided by is always making sure that we're lower than 10C until we get to the 30C mark, and then no more than 4C gradient once we get over that 30C. This is an interesting that's come about, and this falls into not directly our issue, but I feel like that the word is getting out on this. It's the ERAS, Enhanced Recovery After Surgery Society recommendations. Special attention should focus not only on rewarming patients during cardiopulmonary bypass, but also continued rewarming in the ICU with simple methods such as forced air and warming blankets. Hypothermia, less than 36C, in the ICU perioperative realm is associated with an increased risk of postoperative complications such as arrhythmias, surgical site infections, coagulopathies, and mortality. And what could we do as perfusionists to help with this? This tackles that. What should we really be rewarming to? As long as we're following those gradients, we really should be coming off bypass closer to that 37 as much as possible as the surgeons would allow us. So that way the patient has the best outcomes or possibility of staying warm as they're leaving the operating room and going to the ICU, as this has been shown to have many complications in the ICU if they drift below that 36 C mark. Another challenge that's facing the temperature management, as you guys I'm sure know, and I just would like to highlight, at least here in the United States, LiVNova 3T heater coolers are the only FDA approved heater cooler. Everything else is off label. We've been using the CardioQuip here for probably 5 years, and we've recently had a possibility of an infection, and heater coolers are getting tested again. So all water-based heater coolers have that chance of the NTM infections. And LiVNova and Sorin 3Ts are really the only ones that have made some advancements to this. But I just wanted to touch on this. I feel like this is important. A little bit of a Mayo experience. I don't know how much more time I have. I was going to set a timer. But we just recently was in on a trial phase for the Mr. Frosty glycol-based heater coolers. And we ran it through December and January. And we had some challenges that were interesting to kind of share. We like the idea of glycol-based for this reason, the NTM infections. We were able to, when they came, we didn't realize that the only FDA heat exchangers that are approved to run on the Mr. Frosties with the glycol are their heat exchangers. And so you actually have to cut in their separate heat exchanger for the Mr. Frosty, which is an additional $300 cost. Increased prime volumes are another consideration. Another thing to consider is that they have to be recharged. The fluid, the glycol, has to be recharged after every single use. And so it's equal in size to a heater cooler. And so every time you use one, you're going to have to go hook it up and recharge it. And that is very big. When you're like here, we're running 12 to 15 cases a day, and 4 to 5 Circa S cases a week. And another special note, every Circa S case that we did, we had to use 2 charges or 2 heater coolers from the Mr. Frosty, which they alarm and had some issues the surgeons didn't love with the Mr. Frosties. So I felt like it would be interesting for smaller centers. The Mr. Frosty has some promise. It's just coming out, and there's some promise there. But for big centers like here, they pose a big issue with space and with function. I know I talked fast. I don't know how much time I used, but if you have any questions, we can slide into the question phase.
Yeah, Clint, thank you very much for that interesting overview. And what we see, there's a lot to talk about temperature, and that's the reason why we are doing that webinar here. And what we also see that there is missing research. So we want to emphasize all of you, also the listeners, to doing research on temperature. But we have more questions left than time. So I want to pick up one of the questions firstly, and because 2 people or 2 colleagues ask for hemi-arched procedures, and what the speakers are thinking about normothermic or mild hyperthermic approach for hemi-arched procedures with 32 or 34 degrees. What's your opinion about that?
So for hemi arches here at the Mayo Clinic, we're going to cool down to 22. If it's just a Bentall root replacement and it's not getting into the arch at all, then it'd be 30 to 32. See for that protective effect in case anything, and then you're getting closer that if you do need to go down and circ arrest. But the main aortic surgeon here for hemi arches actually fully circ arrests, and his circ arrest times are anywhere from 10 to 20 minutes. And so he'll actually cool to EEG silence and uses retrograde cerebral perfusion.
Yes, retrograde.
Retrograde cerebral perfusion.
Okay.
And he does 3 to 5 circ arrest cases a week, which is pretty incredible.
Okay, great, interesting. I guess I don't know how it's in the other clinics, but from my experience, the most clinics doing an entrograde cerebral perfusion. But yeah, interesting. And what's then the strategy? Are you using a PH or an alphastat approach for hypothermia?
So for hypothermia, we will go on bypass and we'll stay warm for briefly, and then we'll actually pull the blood gas and normalize the CDI, and then we'll actually change to PH stat at 32, and then we'll cool. And then usually they'll tell us when we're getting close to that 5 minutes of EEG silence on cooling, and then we'll blow off all the CO2 and we'll switch to alphastat at that point, and then we'll remain alphastat for the rest of the case. So you don't want to have high CO2 during that circ arrest period.
Okay, great. Reinhard, do you find another question from the colleagues?
Yeah, one question to Christoph Wenck about the locations of the temperature measurements in the Karl cases. Do you have a temperature measurement of the bladder or of the skin? How do you manage that?
So we only have the possibility to measure the blood temperature on the venous side, but we are using, of course, the monitoring of the normal patient monitoring systems. So nasopharyngeal or tympanon temperature probes for measuring the brain temperature.
This was also a question where to measure the temperature, rectal or more near to the brain, obviously near to the brain, and that's what also the recommendation says, to measure the outflow of the oxygenator and then in the nose. Yeah. You already also answered a lot of questions here. I have seen, Christoph. So everybody can read that. Please read through the answers. So, okay. There's one question left from Peter Fast-Nielsen from Aarhus. If you limit the inflow to 37 degrees, it will take forever to reach its central temperature of 37 degree, and you risk an afterdrop in TP, and that can lead to bleeding.
So we've actually we had a surgeon that recently came here, and we've had this discussion. So 37 in, so what would you consider cooking? I mean, what's a fever to the brain? Because you're actually inflow straight into the aortic arch, and it's underestimating. And so it's fine. I mean, as long as you're maintaining those gradients, I guess is it better to have a higher 37 in, higher than 37 in, or be on bypass for an extra 10, 15 minutes? Because you're still been able to maintain those gradients, and we're still able to get to that 36. I mean, he's been frustrated with some of our times too. But the challenge that I would say there is the evidence would point towards what is the fever in the brain, and it's going straight to the brain. So if you turn it up to 38 or 39, this surgeon wanted us to go to 39 to the brain on the arterial inflow. I think that you're risking some edema to the brain because it's a fever.
When the paper came out, we also do that with 37 degrees, and it works. You can also warm the room. Is that possible in your OR? You can warm up to your OR. That also helps to rewarm your patient. So
Yeah, correct. I mean, we have rewarming blankets and air blankets that are underneath the patient. We turn the ORs up to temperature, rewarm, and then the lights from the ORs really rewarm the patient. And it's all about timing, right? And making sure that you start rewarming. That was our biggest challenge with this new surgeon, is he wanted to wait until basically he was done with all the work, and then he wanted us to turn up the heater cooler to 42 degrees. But if you just start rewarming and go to, usually we'll pause at like 30 or 32, and then the last hour is spent, which would be the normal Bentall temperature there.
Yeah. Okay. Thank you. Reinhard, do you have questions left? Something to say?
No, from our side, no more questions. Thank you for your informative answers to you both.
Yeah. Also, thank you from my side, Christoph and Clint. Very, very good presentations. Forget the technical issues. Such things happen. But right. You deliver what you have to deliver, and because we have to talk about temperature. We know we have a lack in evidence. We know we have a lack in the recommendations. And in the next guideline, there will be an extra point talking about temperature. So we also know that we have to talk more and to make more research about temperature management. And yeah, thank you very much. Also to Reinhard, it was your first webinar. You have done that well. Very good. And thank you to all of you. Have a nice evening. And also for the good discussions here. We have a lot of treats here in the Q&A. That's always a good sign that there's an interest in the topic. Thank you very much to all of you. And good night.